Good afternoon, everyone. I'm Michael Barr, the Joan and Sanford Weill Dean of the Gerald R. Ford School of Public Policy at the University of Michigan. It's a great pleasure to welcome all of you to this virtual policy talks at the Ford School event with my colleague Paula Lance, Associate Dean of the Ford School and the James B. Hudak Professor of Health Policy. I think Jim and Sally are on the line now, so I just wanted to pause and say thank you, and I hope you enjoy the discussion this afternoon. This afternoon, Paula and I will be talking today about the emerging social epidemiology of COVID-19 and some of the current responses to the pandemic by state officials, public health experts, and policymakers. We'll also be discussing the clear inequities that have been further revealed by the virus in the United States, inequities along longstanding racial, economic, and social lines. Let me briefly introduce Paula Lance. In addition to serving as the Ford School's Associate Dean for Academic Affairs and the James B. Hudak Professor of Health Policy, she also holds a joint appointment as a Professor of Health Management and Policy in the School of Public Health. In recognition of her influential scholarship and policy engagement, Paula is an elected member of both the National Academy of Social Insurance and the National Academy of Medicine. She's also a beloved member of the Ford School family. She positively influences almost everything that goes on in the Ford School. I'm looking forward to talking with her today about such an important topic. Before we dive into the discussion, let me give you a couple of notes about format. We'll have some time towards the end of the event today for audience questions. If you're watching on Zoom, please use the Q&A function at the bottom of your screen to send us your questions. We hope you'll also use the Zoom chat to engage in a conversation about the discussion with your fellow audience members. It's a great way to engage with each other. For those watching the live stream on other social media platforms, please tweet your questions and comments to us using the hashtag #PolicyTalks. And without further ado, welcome, Paula. It's really nice to see you.
Hi, Michael. Nice to see you as well through the computer screen.
Through the computer screen, as many things are today.
That's right.
Let's get started just with a general sense of what is it about this novel coronavirus that has led to a global pandemic in such a short period of time, really all across the globe. What is it about the science of this and the epidemiology of this that's led to such rapid change in such a short period?
Great question to start with. And before we dive in, I actually do want to say that it's a nice opportunity. I'm not going to say this is going to be fun, the entire discussion, but it's a nice opportunity to be talking with you today and with our community about what is really the biggest public health crisis in many of our lifetimes, for sure. And I also want to acknowledge that there are likely many people participating in our webinar today who have experienced COVID-19 themselves or have had a family member or a loved one get this illness, and it can have very serious consequences. Some people might have even lost a family member to COVID. So I want to start by acknowledging that this pandemic has affected all of us socially, economically, in terms of our day-to-day lives, but it also has likely affected some people health-wise as well. So again, it is really an important topic to be talking about. So the disclaimer going into all this is that this is a novel coronavirus, so it's new, and the virology of it, the epidemiology of it, the understanding it from a medical point of view is all still evolving day by day. I think now many people in the world now kind of know what epidemiology is. That wasn't the case before, and lots of people now are armchair epidemiologists, which I think is great, because there's a lot to know and understand about this, so we can understand what is happening in our communities and in our lives. But again, a lot of the science is emerging. What is understood right now is that you really couldn't, if it was intended, design a better virus for a pandemic, right? So here we have a virus that can spread from person to person, from someone who has it and doesn't ever even have any symptoms. They're asymptomatic, even though they have the virus and but no illness with it. Also, people can get the virus and then spread it to others while they're in a pre-symptomatic phase. And that can last up to 14 days. And in some cases, it appears perhaps even longer that people before symptoms appear. And again, people are infectious, so they can be transmitting it to others. Many people who get COVID-19 is the disease that's caused by the coronavirus. Many people can get COVID-19, but not really even feel sick enough to stay home, to stop interacting with family. And so all those things are bad. They're bad for community spread. And then also we know that we're still trying to figure out exactly what the reproduction rate of the coronaviruses, the novel coronaviruses. So epidemiologists here, I'm going to get a little technical, but again, we're all armchair epidemiologists now, right? So epidemiologists, when they're looking at an infectious disease outbreak, want to understand what is referred to as the basic reproduction rate, or the R0 or R0 in math terms, which is essentially what the basic reproduction rate of an infectious disease is. If a person has it, how many other people on average in a population will catch that virus or that infectious agent from someone else? So influenza, or average influenza reproduction rate, is 1.3. Anything over 1 is going to keep growing in the community. We need to get the reproduction rate under 1. That's the only way that a virus or other kind of infectious agent with community spread will die out in a population. So we want to.
So if I have it and I give it to other people, it'll keep spreading.
It'll keep spreading.
We can get fewer people, if I give it to, on average, maybe a half a person,
right,
then the rate will go down.
Exactly. So we need to get it under 1. If it's over 1, that means there's growth, and then there's always exponential growth. So influenza is 1.3, and then with influenza, people are often really sick pretty much right away. They take to their beds, they stay home, they're not out in the community. Measles has a basic reproduction rate of 11 or 12, so that's terrible, right? Measles is super, super contagious. What we understand right now for the novel coronavirus, we don't really know what the basic reproduction rate is. It's been estimated to be anywhere between 2.8, which is not good, and maybe even up to about 6. But even let's take it towards the lower end. Again, that's bad. So again, the stars are all aligning in a horrible way. You've got something that's fairly contagious that can reproduce pretty easily in the community for all the reasons that I've talked about. And also, when you're in that situation and you don't have a vaccine, and you don't have super effective medical treatment for the people who get really sick from it, that is just the horrible, terrible situation that the world finds itself in right now.
Paul, I think you have a picture you want to show us about, or a chart about what the growth rates look like in the US and the world. Is that something you want to share with us?
I don't have a chart, but I do. If Chris would pull up the slide number 2, which is a table. Any chart that's going to show this in the world is going to show exponential growth. So let's go back. Yeah, so that chart. So where we are in the world right now, and mind you that the first known cases of this novel coronavirus appeared back in December. Not even 6 months ago. So this was as of June 15th, a couple days ago. So we're at about 8 million known cases and 434,000 at least deaths. Both of these numbers are seriously underestimated. Let me be clear about that. Right now, the United States has the terrible distinction of being the country with the highest number of cases. And also, if we put that into a rate, per population, we're even worse, right? So, because we don't have the largest population in the world, but we have the largest number of cases, largest number of deaths. Right now, Brazil is in the 2nd place for this, and it's growing very fast in Brazil. You can see the numbers there. Michigan, we are, again, these numbers are a couple days old. So now we've hit 60,000 cases in Michigan. We're a little bit over that, and we're approaching 6,000 deaths. The first case in Michigan was diagnosed on March 10th. That is not, I know it feels like an eternity to all of us. March 10th seems like a long time ago, but it really wasn't. And this is a devastation that's done in this amount of time. And we can talk about what it might have looked like under some different policy emergency orders. Vietnam, I put on the slide for a number of reasons. One, Vietnam is a country that has the same population as Michigan, so about 10 million people in Vietnam. It's also a country, it borders China. When the virus first appeared in China, countries in Asia, and especially countries that border China, like Vietnam, were very concerned and took immediate action. You know, and we can talk about whether or not you want to believe these numbers or not. I'll tell you that I actually do believe that Vietnam has had very few cases, and to date, they have had 0 deaths from coronavirus. So it is.
Here's a developing country. We're
right.
one of the richest countries in the world. We're going to talk a little bit about why we haven't been able to wrap our arms around this. And maybe, you know, one avenue into that is to look at states that did and didn't take aggressive action in response to the virus. So, you know, there's been a huge amount of controversy about the way in which Michigan put in place pretty strict orders
Exactly.
to limit the kinds of interactions we have with each other to try and you know, reduce the infection rate, reduce the transmission rate below 1. How effective have those been? Have they been effective enough? How do they compare to other states?
Right.
We have a national policy on this right now.
Right. Yeah.
So we're seeing states do wildly different things. How has that turned out?
Well, when states do different things and countries do different things, it actually gives nerdy policy analysts like all of us at the Ford School the opportunity to use natural experiment research designs to try to, you know, really understand what has been the impact of these things. I do want to back up for a minute and just say that there in the history of people, there have been a number of bad infectious disease outbreaks in the past, right? And there has actually been a fair amount of research regarding and when you have infectious disease outbreaks with community spread, so person to person, when people are just out living their lives, what are the kinds of things that we already knew going into this pandemic are the kinds of things that work? And a big heading of those things is called, and I'm sorry, this is a technical term, but people use it, it's non-pharmaceutical interventions. These are the public health tools. And what does that mean? Well, again, when you don't have a vaccine and you don't have effective medical treatments, you need to look to these non-pharmaceutical interventions that are given to populations. They're not given to individuals like a medicine or a drug, they're given to populations. Non-pharmaceutical interventions include these buckets of things. One is a whole big bucket of public hygiene measures. So cleaning surfaces, wearing masks, people wearing masks in public, staying 6 feet apart, washing your hands. All these sorts of things are in the public hygiene bucket, and they generally work with most kinds of infectious disease to quash the person-to-person spread. Social distancing measures are the other really big bucket of things. So stay-at-home orders, closing schools, banning large gatherings, closing non-essential businesses, closing public spaces. All these things we know from pretty good research that was done through the influenza pandemic back in 1917 and 1918, through the polio epidemic that the world faced in the past. We know that these things are really important and they need to be put in place, and they need to stay in place long enough to get that community spread down below that 1 number. And then also there's another bucket of things, mobility restrictions, right? Which most states haven't put them into place. Some have, but mobility Mobility restrictions, no travel into a jurisdiction, no travel out. If you're going to travel in, you need to be under quarantine. Quarantine is a public health word for when people who aren't sick have their mobility restricted. So if you're under quarantine, you're not sick, but you're not allowed to, in this case, for Hawaii, for example, if you wanted to go to Hawaii right now, which sounds kind of good, if you went to Hawaii, you would have to spend 2 weeks in quarantine before you could go out into the community. Isolation is another public health tool that, so people who have symptoms or people who have been exposed to someone with the disease are asked to isolate, so stay away from other people. And there are public health laws that actually can force people into quarantine and isolation and really restrict people's movement. We haven't seen that much in states in terms of that, a little bit, but not a lot. So really it's the public hygiene methods and the social distancing methods. So what do we know about the impact of that? Let's start with Michigan. So Chris, if you could bring up slide number 3. So this slide shows the results of some modeling work that's been done by colleagues of ours here at the University of Michigan in the School of Public Health. Professors Emily Martin and Marissa Eisenberg have led a team that really looking at, what would we have expected in Michigan in terms of the coronavirus outbreak? And then what did we observe with social distancing? So what would we have expected without it? And what did we observe with it? This is a basic tool of epidemiology, comparing expected and observed. Do that a lot. And so the modeling for Michigan, using a lot of assumptions, again, assuming reproduction rate, effectiveness of these sorts of things, and then using data, the daily data that is generated in the state and made public. The conclusion as of June 1st was that without the social distancing measures that were implemented in the state of Michigan, we would have likely seen 28,000 more cases of COVID-19 in the state and probably about 3,500 more deaths.
It sounds like the stay-at-home order had a pretty dramatic effect in reducing the reproduction of this virus.
Very dramatic effects. And it's not just sort of, homegrown people at the University of Michigan who have come to this conclusion. If I could have the next slide as well. Up there, there is, so that'd be slide number 4, right? So there's a group of researchers at the new Imperial College in the UK who are really looking at what's going on in the world with coronavirus and what has been the impact of government emergency orders on the virus, on its spread, and on deaths, et cetera, across the globe. They released a report last week that looked at what was happening in the United States, and they actually gave a great thumbs up to the Great Lakes region of the United States, saying we are in the Great Lakes region doing a very good job at flattening that curve and containing the virus. And they gave special props to Michigan. And this chart shows that this is a 7-day average of newly lab confirmed cases, and it shows that it's going down. And another thing that this study determined is that they think right now in Michigan, we actually do have the reproduction rate below 1. And that's why it's all the social distancing and the public hygiene measures. What they need to do is stop that community spread, stop the average number of cases from person to person. And if we can get that below 1 and keep it below 1, we'll be okay.
Obviously, Paula, there are lots of trade-offs, that states are making between, thinking about when to open up, and getting that R below 1 is so key. Are you nervous at all that as we begin to see changes in policy, that number will go back up?
Very nervous. I'm not gonna sugarcoat it at all. I'm extremely nervous about this. I'm sure all of you are reading a lot of news reports. There's a lot of concern about, second waves. There's concern about surges. There's concern about second waves in places that haven't even finished their first wave. But today in the news, there is concern about a number of states that have opened up and are seeing um, increases, and not just sort of leveling off, but increases in the number of cases and the number of hospitalizations. It's a little early to see the number of deaths, but in some places those are rising as well. That includes states like big states, Texas, Florida,
Florida,
Arkansas, North Carolina, and South Carolina are the 6 states that are getting a lot of attention, but we think this is happening in other places as well. Now, what you hear a lot, and unfortunately, all this has become super politicized, right? So what you're hearing a lot in the press too is like, well, the number of cases is going up because we're doing more testing. And that's absolutely true. The more, it's a fact, the more in any kind of disease, any kind of epidemiology or healthcare situation, the more you go around looking for a disease, the more you're going to find, and the cases are going to go up. So that could be explaining part of it. But what you really want to be watching is, 7-day averages in terms of cases. What are those doing? And then also what's happening with hospitalizations and deaths. That's where we need to be worried. And in all those states, the trends are really quite alarming. Quite alarming.
Another really disturbing fact of the COVID-19 crisis is that it's really reinforced and laid bare all the racial and economic and social inequities in our society. They're reinforcing the impact of the disease, both who gets it and then what the outcomes are for the people who get it. They're just much worse for African Americans. I know in Michigan, we have 14% of the population is African American, and 40% of the deaths from COVID-19 are hitting African Americans. And so I wonder if you could just help us unpack that. Sure. What's going on? Why is it happening? Right. Let's just start with that, and then we can think about the next question, which is what to do about it.
What to do about it, right. So
but just paint the picture for us, what's going on and why.
Sure, and I do have a couple of slides about that I think will help get our conversation going. So slide number 5, please, the social epidemiology of COVID-19. And I think while, everyone right now is an armchair epidemiologist, I think more and more people are also becoming armchair social epidemiologists, which I love as well. Because I think I think people are really understanding how every kind of outcome in our society, education outcomes, economic outcomes, health outcomes are all patterned by socioeconomic status, by race and ethnicity, and the way in which everyone in our society interacts with all of our social structures and our systems. And that's what social epidemiology always looks at. So first of all, what do we know? What are the individual level risk factors for COVID-19 exposure? We do need to start with that, right? So who's being exposed? Who has a higher risk of being exposed? And then once exposed, who has a higher risk for serious illness and death? Let's just start with that. So we do know people who live in, who are in congregate living situations like nursing homes, rehab hospitals, psychiatric institutions, and also people who are incarcerated have higher risk for getting COVID. And I just do want to give some numbers to you. Nationally, 44,000 people who are currently incarcerated have gotten COVID. 462 of them have died, and those numbers are just going up and up and up. Some states that are seeing a rise in COVID right now, a big part of that is due to the increase in both nursing homes and in prisons and jails. there are certain occupations, obviously, where people are more likely to be exposed to the virus and then get the disease from it. Healthcare workers, first responders, other kinds of frontline service workers, people working in meat packing plants, et cetera. And then also, CDC has all their guidance for what all of us as individuals can do. Wear a mask, wash your hands, do all that. But some people just can't, they're not able to, not because they don't want to, because of their structural situation, aren't able to follow this sort of basic hygiene advice. It's hard to wash your hands if your water's been shut off, right? It's hard to stay home from work if you are reliant on that income. You don't want to get evicted and you don't have paid sick leave. If you're relying on public transportation, et cetera, et cetera. So exposure, a lot of people talk about viruses as if they're the great equalizer among us. Viruses don't have biases. Viruses aren't racist. Viruses don't discriminate. That virus, we're not going to anthropomorphize the virus. It's a virus, right? But there are many, many things about our society and our social structure that put people at different risk levels for exposure. So we got to understand that first. And then once exposed and getting COVID, there are risk factors for serious illness and death. So it's very, very clear. It doesn't matter what country you're in. If you're older and age 65 or older, you're going to have a much harder time with this virus. So age in and of itself is an issue. But also, net of age, people with certain chronic conditions are really getting very, very sick and are the people who are the most likely to die from COVID-19. And chronic conditions like lung disease, asthma, certain heart conditions, including hypertension, diabetes, chronic kidney and liver disease. And if you are immunocompromised, that's not a good thing either. But also, can I pull up the next slide, please? So we know that racial and ethnic minority status is definitely quote, a risk factor. I don't know if everyone can see, I can't quite see the whole slide here, but let me read the numbers to you. So and a study actually just came out by the Brookings Institution that said, a lot of states, Michigan included, Michigan was one of the first states to start reporting COVID cases by race and ethnicity. I'll note, if you just look at the crude rates by 100,000, nationally, it looks like the rate of getting COVID is 54 per 100,000 people for African Americans. I just got notice my computer is at risk for a virus, so sorry. I have to turn that off. Not COVID. All right, so 54 per 100,000 for Black people in the US, 26 for Hispanic, 26 for whites. But different populations have different things. It's a little easier to read, have different age distributions. And if you have a population that has an older age distribution, you're gonna see probably more cases versus a younger age distribution. Well, it turns out that the age distribution for Blacks and Hispanics in the United States is a little bit younger than for whites. So if we adjust for that, the rates of COVID are even worse than we thought, just looking at the crude numbers. It's 72 per 100,000 for Blacks, 50, this is the death rate, 50 for Hispanics, and 20 for whites. So you see, it's almost
huge differential disparities in
again,
outcomes.
It's worse than we thought. So, not surprised, but again, it's worse. So, Chris, you can take the slides down, please. I mean, there's so many different ways to think about this. Why is this happening? But again, from a social epidemiology point of view and a social science and a policy point of view, importantly, we need to not explain this away. Oh, well, Black people are dying more from COVID because they have more chronic health conditions. Let's back up. Why is that the case? Why is it the case that rates of diabetes and hypertension, And obesity actually turns out to be a risk factor as well. Why are certain people in our population, first of all, more likely to be exposed and then have a harder time with it? And here's where we really need to look at, again, those social structures that structure access among people to resources and opportunities and privileges, and also structure being exposed to risk and marginalization and disenfranchise of communities and discrimination. I'll stop. See how you want to take this.
Yeah, I think Paula, no, I mean, it's a just absolutely central topic. I mean, one of the things you've highlighted is the way in which structural racism in our society means that African Americans, Hispanics are going to die at much higher rates than whites from this disease. There's also the structural issues that mean that our work in helping to prevent spread is also disproportionately affecting these same communities economically.
Right. Right.
And I'm wondering how you think about that.
There's so much going on. I mean, this is like the basis of social inequality in our societies, which is hard enough to think about. And then let's layer on COVID on top of it. I actually tried to put together a little figure to help sort of talk about it and think about it. So Chris, if you could pull up slide number 8. Here. So again, the important thing for us to think about and understand is that the macro level systems and institutions and public policies that are in place that drive socioeconomic and racial inequality in the first place are the root cause of health inequities. And so we start with that. We have economic, political, social, racial inequality in this country that drives every form of health inequity. This is what I've spent my entire career studying, from what drives infant mortality disparities, what drives lead poisoning disparities, what drives cancer disparities. I mean, it's all these upstream macro level factors. The story just keeps playing out over and over again. So it's playing out in terms of COVID-19, in terms of inequities and exposure and outcomes. But Michael, as you rightly just noted, those non-pharmaceutical interventions, right? Those emergency controls that we have to put in place, stay home, don't send your kids to school, we're all on lockdown. It's the worst catch-22 ever, right? Those things are also hitting people in minority communities, lower socioeconomic communities, much, much harder than other people. So people have been talking about this in a lot of different ways, and scholars, have been working on racial and ethnic inequities in health for a long time, are, talking about this as, using terms like, and I agree with all these, the COVID pandemic is just being pushed by a pandemic of structural inequality and structural racism. Colleague of mine, I'm going to read what she wrote. This pandemic is creating chasms where we already had large cracks. And part of what is making the larger cracks is the stay-at-home orders, right? So, let's talk a little bit about that. My kids are grown, they're not home. I didn't have to figure out how I was gonna, be homeschooling my children while, doing all the other things that we've been doing at the Ford School in response to the pandemic and to keep up with our teaching mission. But for people had to figure out how to do that at home when they might not even have internet connection. And also think about how many kids rely on free and reduced breakfast and lunch at school. So food insecurity getting worse when we close our schools, as well as the education. Just as our colleague Sue Donarski, who's an education policy expert, noted recently in a New York Times piece, that basically school ended in March for most kids, but this is just gonna, even further, take that crack in our educational system and make it a bigger chasm.
Paul, let's switch gears a little bit and think about how are we going to climb out of this? What are the steps? I mean, obviously there are a lot of steps we need to take as
Uh-huh.
a country, but when you think about the key steps that are going to help us both with the virus and with the underlying racial injustice involved in the transmission and treatment of the virus, how are we going to begin to climb out of that as a country?
So it's I'm not going to sugarcoat this because it's the same ways that many of us have been arguing we have to climb out of health inequities in general forever, and it's not easy, right? So for in the first response to this pandemic, we obviously need to figure out ways to give people income security and support unemployment insurance, food security, healthcare access. I mean, there's all these kinds of things, and I don't really want to call them band-aids because they're really important, and we're bleeding everywhere, right? So we've got to have a good response to make sure people aren't being evicted and in the foreclosure rate, what's going to happen with that? And again, food security, economic security, all those kinds of things. We need strong government response to that. But also because our systems in general let so many people be living just on the edge. I don't know, Michael, you probably know more than I do. What percent of families and households in this country can weather an economic shock of more than a month?
Yeah, not many.
Not many, right? Um, there's data on housing affordability that demonstrates where the housing crisis in this country is getting worse and worse. There are very few places where someone making the average wage in a community can afford to pay the average rent for a 2-bedroom house. And then healthcare, I think everyone knows it's a mess, right? And the rates of uninsured are going back up, and the healthcare safety net has giant holes in it. So there are many things that need to be done, immediately to stop the hemorrhaging. But if we don't get our systems in place, if we don't think more about social and economic security for people, and again, if we don't do something about the systemic racism in this country that puts communities of color has left many urban areas almost abandoned except for pockets of gentrification, if we don't do something about environmental racism and think that everyone should have access to basic what the World Health Organization calls the basic materials of health: food security, clean water, clean air, housing security, a physically safe environment. If we don't do better on those things, as this virus, the waves crest and go up and down, which is probably what's going to happen when another pandemic hits us, we're going to be in the same situation.
Paul, I'm going to, in a moment, start to weave in questions from the audience we've been getting. And before I do that, let me just ask you, I know you've been doing a lot of research in response to the COVID-19 crisis, and I've been really struck by the number of Ford School faculty as a whole who have really engaged, stepped up with their own research, with engaged learning opportunities for students, engaging in policy impact in the world. I'm wondering if you could just maybe paint a picture for us of that, or give us some examples of what the Ford School community has been doing.
Well, I'm happy to give a couple, and I know, Michael, you know about all these things as well, and so you can share some of the highlights yourself. But I think the Ford School it's a community. Our mission is we're a community dedicated to the public good. And to no surprise to any of us here, everyone pivoted very, very quickly in terms of what they're working on, to not pivot to now look at COVID, but understand how this pandemic is, again, so related to all the other things we do at the Ford School. People worried about climate change and the environment, very worried about what this pandemic is doing in that regard. People worried about education, social welfare policy, et cetera. So just a couple of highlights. So my colleague, Shobita Parthasarathi, thinks about science, technology, and public policy issues. And she quick, with lightning speed, wrote a grant and got some money from the National Science Foundation to study what's happening in terms of the development, implementation, and regulation of diagnostic testing for COVID in 4 countries. So that's exciting work. Our colleague Luke Schaefer and all of the amazing people he works with at Poverty Solutions here at the University of Michigan are looking at the impact of COVID on social welfare of people here in Michigan. And what's happening in terms of poverty rates, unemployment rates, food security, et cetera. Luke and others have been advising the state government of Michigan in regard to how to quickly get unemployment benefits out to people, which is a huge issue, obviously, on the economic side of things. Our Ford School economists like Justin Wolfers and Betsy Stevenson have been on television and writing a lot in the news about, again, like how do we climb out of this economically? I will say that, if you've heard Betsy and Justin and many other economists, they all are, I'm glad to hear, sounding quite vocally and in unison that if we don't get the virus under control, we have no hope of getting the economy back on its feet. So the idea, again, of opening up, letting people shop, go to restaurants, having gatherings, spend money, get people back working, that's great. But if we do that and the virus spikes again, it's not going to help with the economy, right?
Well, that leads me right into the beginning of some of our audience questions. We have quite a few coming in, so we're going to try and clip through them. One question is, when a state or region reaches the basic reproduction rate below 1, like Michigan is now, can we assume fewer social distancing measures make sense? If so, how do these regions then protect against a second wave? How can policy effectively affect the pace of reopening?
Right. $1 million question. That's an excellent question. So basically, unless that reproduction rate is way below 1, you're going to have to be very vigilant. So, Michigan is opening up slowly. And that's the right way to do it. Open up slowly and then keep your eye on the data, what's happening. If things start going up again, we might have to pull back on, some of the things that we're being allowed to do. But if you pull away all the social distancing measures sort of overnight and everyone just goes out and is their wonderful self again out in the world, that I think without any question, again, we don't know, this is a new virus, but I think without any question, that's gonna lead to a quote second wave or another spike. I think we're in for multiple waves, and I think it is going to be this. It goes up. Let's contain it quickly. If you don't, and it gets way above 1, if you get back up to 3 or whatever, then it's much harder. Then we all have to go on lockdown for much longer. Again, I think the trick is going to be, and this is the governor of Michigan's approach. They're going to watch the data and try to be very careful about opening up, and then again might have to pull back. And that might be tailored in different regions of the state, right? So if things start happening in Southeast Michigan again, that doesn't mean the entire state will go back on lockdown, including the UP. I mean, it'll be a tailored sort of approach.
We also have a question moving up from state policy level to national policy level. Why are we doing so much worse than other countries in terms of the coronavirus, the questioner asks. What can we do to stop being the worst in the world in terms of infection and death rates?
I knew that question would be coming. It's hard to answer. I think there are a few reasons why we're doing worse than other places, and I will also say, as a normative statement, we're doing worse than we should be. Part of it was a late response. And part of that is somewhat understandable. Again, the way the virus played out in China and South Korea and Taiwan and Vietnam, and if you were following those countries, uh, as I was, and Michael will remember, and I'm willing to admit that even back in January and even kind of early February, I was like, I don't think it's going to be as bad as some people are saying, because I was very carefully watching other countries and seeing what they were doing. Well, it didn't play out the same way here, obviously. And again, there was sort of a late start in many places to those social distancing and public hygiene emergency orders from governors. Um, and there was already a lot. It was already in the community. It takes a couple weeks for you to know how much is that it's in the community, and it starts hitting your hospitals a little while after that. So we were a little late to that. But the other issues that I really think are ones that become more political, and are less easy to sort of say, this was new, it was tough for everyone, we didn't really know. Um, the US so late to the game in testing. And testing is I should have mentioned this before, infectious disease control cornerstones are these social distancing and hygiene measures, but testing, um, and contact tracing of people who are tested and are found positive, who they've been exposed to, are essential. And we were way, way, way behind on that. And then also, I will
We
say,
don't have a national system of testing and tracing.
no, but we didn't even have even states that have pretty good public health infrastructure were behind the game on that, because we really didn't know. We didn't know it was coming, and we didn't know it was going to hit us like it did. So what we weren't prepared. Um, but the public health infrastructure in this country has crumbled over the past several decades. It's been multiple administrations. Public health agencies are seriously underfunded. There's pandemic playbooks. We got plans for what to do, but not the resources at all to implement them. And the last thing I'll say that has been very disturbing to me is that in the United States, there's been a lot of, I mentioned before, you may not trust the numbers from Vietnam. They have 0 deaths. Do you believe that or not? Up to you. Do you trust the data coming out of Florida? I wouldn't. They're an epidemiologist in Florida who's sort of a whistleblower got fired for saying, I've been told to fudge the data on the number of cases. We're seeing that in lots of states, and it's greatly disturbing to me, because if we can't be tracking the data and we don't have confidence in the data, that is just bad for public health.
And it'll undermine trust in government more broadly, that is essential for getting us out of the crisis.
Exactly.
So we have quite a number of other questions. One, key question that people are thinking about just as they walk around, what happens if, you're wearing your mask and you're in an environment where other people aren't wearing their masks? How do you, what should you do? And should there be law enforcement involved? Should there be social, other social controls? What's the best strategy just generally for the kinds of social norms we need to stay safe?
Yes. So there, we need. I don't think we need law enforcement for masks, because I am quite convinced, without a doubt, that won't be enforced equally across different members of our
We've
society.
seen that already.
We've seen that already. So no, that's not what we need. We actually need better. First of all, we need government leaders to not politicize the wearing of the mask, right? Wearing a mask doesn't make you weak. Wearing a mask doesn't make you, buying into the, left-wing conspiracy about this virus. Wearing a mask doesn't mean, you're, whatever. Wearing a mask is really important. There's some modeling studies suggesting that if everyone would wear a mask, we actually might be okay and not have these peaks where we all have to, hunker down again and create even more just havoc and hardship in terms of what's going on in the economy. So better public communication campaigns that really try to convince people, not at all, it involves trust for sure, but that are, their social marketing techniques need to be used to find pockets of people, what's going to resonate with them, how can you convince different groups of people, the young invincibles. Guys, I'm actually, because there's construction at my house, near my house today, and it's loud, I'm in my office. And walked on campus, there are a lot of lovely, student looking like people walking around without masks, and not social distancing on sidewalks, right? So what kind of campaign do they need? What kind of campaign do we need for, other kinds of people? But masks are important. It's not the only thing, right? But if everyone wears a mask, the transmission rate in the community will go down a little bit, and all these different things layered on top of each other are what's going to help keep that reproduction rate where we need it.
Paula, that goes into another set of questions related to the university's thinking about our strategy for next year. The president of the university has said that he's hopeful that we'll have a public health informed residential experience on campus. Universities making those decisions in the coming days and weeks. What kinds of factors is the university considering? I know that the School of Public Health is advising the administration, as they did the governor of Michigan, on these matters. How should we be thinking about the kinds of steps that might improve the public health outcomes for the university in that context?
Right. Well, we are going to have to keep thinking about these things for a while until there's a vaccine. I bet you had questions about that. I don't know. I don't have a crystal ball, but we're not going to have a vaccine during the next academic year. So we are really, really thinking about this. We are unfortunately going to have to keep 6 feet in every direction. So 36 square feet around all of us, away from each other. We're going to have to think about density issues. We're not going to be able to have giant gatherings. There might be some students happy about this. We're not going to be able to serve pizza and have shared pizza. Students are so sick of us giving them pizza anyway. So we'll have to figure out other kinds of food that's more safe to give people. But there's going to be some rules about masks, hand washing, and the use of libraries and other kinds of facilities. It is not going to be business as usual. But I know, Michael, the message you've been giving people, and I want to give people, is that, there are reasons that we have to do all these things, but also the main thing driving us is that we are so committed to our mission, which at the Ford School, we think is more important than ever right now. Our mission is, we are dedicated to the public good, and we have a teaching mission, and we have a research mission, and we have a policy engagement mission, and this is an election year. And so we're trying to be as creative as we can about ways that we can build our community. We have all kinds of new people coming into our community to build it and have it thrive, and figure out ways that we can communicate safely. Some of it's going to be through our computers like this, but also we're going to think about the kinds of events and small group interactions, and mixing students up by their own volition, as well as, we're probably going to randomly assign you guys to, hang out with each other and talk about issues. And we will still have guests coming in, and we will still learn from each other, and we will still try to have that impact on the world.
I think that's an excellent point, Paul. I mean, we're all about trying to advance the public good. As you said, that involves teaching our students, it involves research, it involves policy engagement, making an impact. And just as we've been doing these last few months, we're going to need to continue to be creative about how we go about our work, because country can't afford for us to not be dedicated to this mission. Right. And so I think, I'm hopeful that the university will come up with a really interesting, exciting, and effective range of strategies. Obviously the university as a whole will be making a number of decisions about this, and then the Ford School we'll be adapting those to our own unique circumstance. We're a tight-knit, small community. so many of our students are actively engaged in the world and will want to continue to be doing that in a deep way. Let me ask you a question that I know many people are struggling with. It's come up in the audience in a few different ways. The question is just how do we cope? You know, in particular, the question says, how do you recommend people stay informed while managing the anxiety of all that this causes?
Right.
How can we effectively fight back against coronavirus fatigue? We're all, I'll just riff a little bit on this. We're all struggling with this in different ways, right?
Right.
Those of us in leadership positions, our students, faculty, the people in the community, there's just so much going on. And layer on top of that, the increased focus, the rightful focus, the protests on the legacies of racial injustice in our society that have really, it's just almost too much to bear for people. So how do you suggest that people who are listening in navigate? We want them to stay engaged. We want to, we don't want to shut down, but it is a lot to be able to process and take on. So how are you navigating it? How do you think about some of our guests online might think about navigating it?
Right. I think everyone is struggling with this, and how to best cope with the world right now is going to be very personal for people. I think some things that cut across everyone are that sleep is important. So there's a rule at my house that I am not allowed to read the news after 10 or 10:30 at night, because I just end up getting more angry and upset and say to my partner, and now do you know what the numbers are? So like, no, try to shut down. I know a lot of people are turning to, mindfulness activities, just finding ways to, it might sound like, oh, what a luxury. You could spend time thinking, about yourself, but it's more physiological, right? If you can, because I think a lot of people's your blood pressure might be up and you don't even know it, right? So, just trying to find ways to calm yourself physiologically, so you feel then rested and able to do the important work that you all need to be doing right now. And then, so the other thing is everyone find your passion. And also, I'm motivated by anger a lot. So there's a lot of things I'm angry about in the world right now, but I want to try to do something about it. So figuring out, prioritizing, what do you care about? Your family, your friends, your health is number one, right? So what do you need to do to protect those things? And then what are the things that you're really passionate about in the world that brought you to be interested in public policy, that brought you to be interested again in what's happening in the world? Find ways to do those safely, and then also find the things that bring you joy and passion for fun. If it's running, some kind of outdoor activity that we can finally do in Michigan again, if it's cooking, if it's knitting, if it's Zoom chats with your friend, like make time for all these important things. And I think it's okay that that everyone is feeling frustrated, lethargic, scared, sad. It is the world we're living in. We have to admit it and then pick ourselves up. The other thing I will say is, if you really are struggling, you find those people who will help you and get, the resources that you need to get your health, your mental health and your physical health in shape for the important work you want to be doing in the world.
Well, Paula, I think that's a great note to end on, an inspiration, a call to action, a call to rejuvenation, because it is so hard right now. Being able to have a mission and to work on that mission and to take care of yourself, I think is so critical. And I want to thank you for walking us through this important issue this afternoon. I'm sure everybody has learned a lot and thought about new ways they might get engaged. And I really appreciate your time this afternoon. I know you're super busy, so thank you for joining us. And
it was an honor.
Thanks to all of you who joined us online. I know we had a lot of people joining us on Zoom and other social media. Hopefully you'll tune in for another Fard School policy talks later this summer. We'll continue our series and look forward to seeing many of you again. In the meanwhile, let me just say thanks for joining us, and of course, go Blue.
Thank you. And then some of our incoming students I'm going to be chatting with again in a little bit this afternoon. So those of you who are going to be new to the Ford community in the fall, I look forward to chatting with you a little bit more later today. Thank you.
Take care.